Hi, I'm Truck, a former social worker.
And I'm Janine, a former case manager. We are currently psychiatric nurses, but we remember what it's like to work in community mental health without a background in neurobiology or pharmacology.
Our goal is to help case managers and social workers better understand what their clients are experiencing so that they feel competent and confident that they can meet the needs of their community mental health clients.
The module discusses neurobiology and treatment of depression. Before we begin, we believe that you'll have the best learning experience by downloading the guided note sheet while following along with this presentation. The link to download this is just below. We'll talk about the types of meds used in this presentation, their side effects, and specific issues that may come up for your patients that you might need to address, such as when they say, "I want to stop taking my meds." Let's get started.
The classic neurobiology theory of depression is that some people just don't have enough brain chemicals, often referred to as neurotransmitters, for their brain to work normally. Some examples of these brain chemicals include serotonin, norepinephrine, dopamine, GABA, and glutamate. This theory, however, is not as strong as it once was.
Current research indicates that these neurotransmitters aren't as much of the problem as the receptors that they fit into. Let's use serotonin for example because it's highly involved in regulating mood. Imagine serotonin is a key and a serotonin receptor is a lock. When the key fits into the lock, a message is sent to the brain to start or stop the release of other brain chemicals that affect the person's mood. So as you can imagine, if the lock is broken or doesn't work right, the person's mood is affected.
Recent research on depression has also shown that inflammation of the brain can also be involved in depression. Inflammation can be reduced by neurotrophins, which are proteins made by the brain which help keep the brain cells healthy, a kind of soup for the brain. Some antidepressants help the brain produce this soup.
So, let's talk about antidepressants. There are several classes of antidepressant medications used to treat depression, but we'll just focus on two groups that are most often used in community settings: the selective serotonin reuptake inhibitors, or SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs.
In general, these drugs work not only by merely increasing the amount of neurotransmitters available, but they also change gene expression as well in the process. In other words, think of it as not only increasing the amount of keys available, but also fixes the locks in the process, making it easier for other keys to fit into them in the future. In general, it may take up to 6 weeks for these medications to begin relieving depression.
There are many different types of SSRIs and SNRIs, each interacting with other brain chemicals and receptors in addition to their primary target of serotonin or norepinephrine. As you can imagine, side effects are far-reaching and complex as a result. Patients taking an SSRI may complain to you of having nausea or diarrhea, more anxiety initially, weight gain or weight loss, sleepiness or insomnia, or sexual side effects. In addition to those symptoms, patients on SNRIs may complain of lower high blood pressure as well.
One side effect that we are really concerned about with these drugs is called serotonin syndrome, in which the patient becomes suddenly very feverish, anxious, has abnormal jerky or rigid movements, and appears disoriented or even not making any sense. This can literally happen within hours of taking an SSRI and is considered to be an emergency situation.
Another very concerning side effect is an increase in suicidal thoughts. People starting new antidepressants should be educated about this by their healthcare provider, and it's important for the patient to seek help if suicidal thoughts begin or get more intense after an antidepressant is started.
When your patients are on these meds or any other psychotropics, you'd really want to encourage them to drink a lot of fluids because these meds are cleared by the liver and the kidney, and eat a well-balanced meal to provide the building blocks for neurotransmitters. In other words, meds won't do them any good if they don't have the basic ingredients to make those brain chemicals.
You will also want to encourage your clients to create a list of physical and social activities that are pleasurable for them in order to augment the effects of the medications, and preventing them from spiraling further into depression, and also to offset some of the side effects such as weight gain or anxiety.
As you already know, sometimes side effects can be so severe and uncomfortable that the patient may tell you that they just want to stop taking the medication altogether. In these cases, always encourage them to discuss this with their prescriber and make sure that their discontinuation is medically supervised, because oftentimes a sharp drop in medication level may cause symptoms to reappear and cause rebound depression. Of course, it also goes without saying that if the patient reports side effects or a desire to stop the medication, you'd want to stop and notify their provider as soon as possible.
Lastly, we want to stress that psychotherapy plus medication has been shown to be the most effective treatment for depression. New connections are made between brain cells during therapy processes. When antidepressants help bathe the brain in neurotrophic soup, reducing inflammation, the nourishment also helps these connections last longer and helps prevent future episodes of depression.
Thank you for watching our module on depression, created as part of a Masters of Nursing scholarly project through Seattle University. Please check out our other modules on anxiety, ADHD, bipolar, and psychosis and schizophrenia.
Thank
Thanks.
you.